Focus of today's webinar is going to be an update on COVID-19 vaccine efficacy. But as usual, at the start of the webinar, we're going to get an update on the epidemiology of COVID-19 in the Western Cape. And this afternoon, we have Erna Morden, who is the Deputy Director of Epidemiology and Surveillance at the Western Cape Department of Health, who's going to share with us the most up-to-date data on the epidemic in our province. So over to you, Erna, and thanks very much for presenting this afternoon.
Thanks very much, Graham. Can you confirm that it's screen sharing? And
yeah, we're seeing the screen. Yeah.
In slideshow mode.
Yeah, that's very clear. Thanks.
Thank you so much. So I'll be presenting an update on COVID-19 and the epi in the Western Cape. So starting with the graph, that's the integrated graph looking at testing, cases, hospitalization, and mortality trends. This graph will be familiar to those who has regularly attended the ECHO, and it's nearly 2 years to the day since South Africa went into lockdown or hard lockdown. So 2 years of COVID. So just a quick refresher, that cases in black, and then oxygen use in green. We've got hospitalized patients in blue, and then test positivity in yellow. And so just to note that cases they've come down, and so has positive proportion, but they are still higher compared to previous interwave periods. Admissions are now below previous interwave periods, and deaths have come down as well, are low and are similar to previous interwave periods. So looking at national trends, so all provinces are in a post-wave period. It does seem as though there might be an uptick in the Eastern Cape and KwaZulu-Natal. And just to note that these trends are from the South African Modelling Consortium, and this week was their last week to do the update. And it'll be the last, barring any changes to the pandemic situation. And then if you look at the graph at the top, this is from the NICD and looking at the 7-day moving average of cases, generally low across all provinces, but again, across the country, not quite down to previous interwave periods. So now zoning in on the Western Cape as a whole, it's still quite flat in the province, and there's been a very slow decline in the daily number of new cases, and currently around 300 per day. And then just to bear in mind that this is compared to a week that had a public holiday, so compared to last week, there's been an 11% decrease. And then we've seen slight increase in admissions, but that's only around 20 per day, and deaths are still quite low. And then the positive proportion really has remained persistently high coming off the fourth wave for the Western Cape. Right now it's around 19%, and if you're looking at the bars, so the gold mustardy color is the private sector and the blue is the public sector, you can see that testing seems to be driven by the private sector. And just to note that the public sector testing criteria is still unchanged and is the same as what it was when we were in the fourth wave. So now zoning in on the metro. So overall for the metro, there's been a 10% decrease in comparison to last week, with upticks seen in Khayelitsha, Klipfontein, and Northern. Although there are upticks, it's just also important to note that numbers are still very low. Looking at metro now, there's been a 15% reduction in the metro. Again, reductions across most areas. Central Karoo the percentages tend to be wonky because numbers are extremely low there, so that's not calculated. And again, similar picture as the rest of the province with numbers coming down. So then looking at the RT, I know the zoomed in graphic looks quite alarming, sitting right above 1 over there. But if you're looking at the zoomed out one, you can see that it's been hovering around 1 for a good few weeks now. And this is in keeping with the plateau that we are seeing in the province. And then across the districts, you can see it is largely sitting around 1. And it is based on case numbers. So, if we're not testing enough or we're seeing big jumps, it will affect the estimated reproductive number. So looking at the short-term forecast from the Modelling Consortium, so new cases per week. So looking at actual numbers from the previous week is largely on par with the predicted values. And then the predicted cases for next week are similar to the prior forecast. I mean, if we zoom in a little bit, there might be a slight increase. But again, just to note that this is the last week that the modeling consortium will be doing these predictions. Now moving on to the median cycle threshold, or CT values. So to orientate you, so this is the country as a whole, and then by the provinces, the turquoise line is the median CT value. I think it's a 21-day average, and then the red bars are cases. So generally, the CT values reflect the median viral load. A low value shows an increase in the viral load. In the past, a drop in the CT value has shown the start of a new wave. So nationally, we are seeing a drop in the median CT, but important to note that this is against a background of low case numbers. The Western Cape, if we looked at the Western Cape as a province, it was coming down, but with the most recent data, it's showing a slight increase again. And this just shows, as seen with other provinces, that there's been a drop in the median CT without the start of a new wave, and then the median CT increases again. And so again, it's the low case numbers that make this quite difficult to interpret. So now moving on to genomic surveillance. So South Africa, the last genomic surveillance was week ending 12th of March, and Omicron is still dominant in January and February, and as latest available data, so nothing new there. In February, it was 85% of all cases was BA2. And in the Western Cape, it's looking exactly the same. Most recently available data shows continued dominance of Omicron BA2, and then we've had sporadic Delta cases identified, but very, very low in number, and nothing more recent as yet. And then lastly, just looking at the MRC excess deaths. So nationally, deaths due to natural causes have plateaued and is tracking along the upper prediction bound. And in the Western Cape, it does appear as though excess deaths may have increased in the most recent weeks, but this is still below the upper prediction bound. And I will leave it at that. Thank you.
Thanks so much, Ona, for that update. Really useful to see the data. If I could just ask one question, you know, in some of the previous interwave periods, we've seen sort of sporadic outbreaks and clusters, particularly among young people. Has there been any detection of that phenomenon currently?
We keep looking, and we're not really finding anything. There's no specific pattern coming out. I think we did see an increase at the start of the year among school-aged children, with schools opening up some more, but we haven't really seen anything yet. And again, I know we're moving away from case-based and testing metrics. So if maybe we're not testing enough, but it's difficult to tell, but we're not picking up any specific patterns and clusters or outbreaks just yet.
And how much, you know, obviously testing has gone down because of guidelines. How much less testing are we doing now compared to previous interwave periods?
I'll have to check. I'm going to guess and give you the wrong answer if I tell you right now, but it is something we can look at as the EP team to check how much lower testing is compared to previous interwave.
Okay, great. Maybe at the next session we can discuss that further.
Sure.
Thanks so much, Ona.
Yeah.
Appreciate the update.
Thanks.
So we're going to move now on to our main discussion for this afternoon, which is really focusing on COVID vaccine efficacy. And you'll be well aware that when the first data from randomized controlled trials came out on the efficacy of COVID vaccines, the Pfizer and the Moderna trials, efficacy was around 95%. But since that time, the landscape has evolved substantially with the emergence of immune escape variants, waning of immunity in some individuals, reducing the efficacy with respect to protection against infection. But then we've seen the introduction of booster doses, either homologous boosting with the same vaccine or heterologous boosting with a different vaccine that has restored efficacy in some studies. And we've seen a decoupling of protection between the protection one receives against infection and the protection one receives against severe disease and death. And obviously, most of the data has really reassured us that the vaccines remain highly efficacious at protecting against severe disease and death from COVID-19. but it does and it currently remain a very complex field because of all of these dynamic changes in our understanding of vaccine efficacy. And this afternoon, Nigel Garrett from CAPRISA in Durban will give us an update on the current state of knowledge with respect to COVID vaccine efficacy. Nigel is very well positioned to provide this update. He's the head of vaccine and HIV pathogenesis research at CAPRISA in Durban. He's a specialist physician in HIV and sexual health, and he's conducted more than 20 randomized controlled trials and large cohort studies related to COVID-19 vaccines and HIV prevention, and is published on topics including vaccines, HIV prevention, and sexual health. He currently acts as international co-chair on the CoVPN 3008 Ubuntu mRNA vaccine trial, co-PI on the Sisonke J&J COVID-19 vaccine study, and is also PI on several NIH self-initiated grants. So thanks very much for agreeing to our invitation to speak this afternoon, Nigel, and we're really looking forward to the update.
Thank you so much, Graham. I'm just going to share my slides, if you can.
Yeah, we're seeing them, and it's in full screen, so that's okay. All set.
Yeah, thank you so much, Graham, for this very long introduction. I don't think I really deserve a lot of this credit, but I think essentially this topic also raises that point that, you know, not everyone, not one single person can really understand these topics on their own. And what we're trying to do, I think, with these forums like you've put together during the pandemic is to really get people to exchange these ideas and learn from each other. So I think that's been a wonderful experience, and I've been on several of your talks. So I'm going to talk about the current state of the knowledge on COVID vaccines. And I'm going to focus on efficacy. I think there's a lot to be said, obviously, on vaccine safety as well, but I think today we'll just talk about efficacy. Graham, you already mentioned briefly that I'm the PI on as part of the CoVPN, the prevention workshop with the NIH. I've been a sub-investigator on the Ensemble trial that some of you know about. I've also been a co-national PI with Glenda Gray and Linda Gale-Beck and Amina Goga on the Sisonke study. And currently I'm a co-chair together with Philip Kotze, who's on as well, on the Ubuntu trial, mainly for people living with HIV, looking at the Moderna vaccine. And we are planning to do one more dessert for everyone in Sisonke, and I'm going to try to introduce that study to you on this call. So I'm just going to very briefly touch on the epidemic. I think you've already heard it before, so I may skip over one or two slides. Very quickly talk about maybe one or two slides on vaccine concepts, because I think it's important in terms of understanding some of the findings. Latest efficacy data and then recent studies. Touch briefly on heterologous boosting because that's become quite popular now, and briefly talk about what we've been doing recently in South Africa with Sisonke and other studies, and then how can we move forward. So just for maybe international participants here on the call, you've seen the 4 ways that Erna presented, and just to maybe remind everyone that we did run these clinical trials during various different waves, and they all had different dynamics with different variants. So when we interpret vaccine trial results, it's very important to think of the dynamics, the force of infection, and also the dynamics of each variant. We've just seen that, so this just reminds everyone where we are with the variants. So, for example, when we ran the Ensemble trial, that was the first study that really described efficacy during the beta outbreak here in purple. And then some of these other studies looked at, like Sisonke, for example, looked much more at Delta, the light blue or turquoise. And then obviously we've now starting to get some nice data out on Omicron, and which has now evolved into BA2. So one important message, I think, for all of us is the quite high mortality rate, obviously across the world, really, globally, But then if we look on the left, you can see the ratio of excess death, and the more red or orange, the higher that ratio to reported death. And I think one thing is clear, that certain parts of this globe, particularly in Southern Africa and maybe Southeast Asia, we see very high rates of excess death, which presumably tells us, that the healthcare systems were just not strong enough to deal with COVID, the consequences of COVID, but also then additional morbidity at the same time. So overall, we've got this excess mortality rate of about 120 deaths per 100,000, which is incredibly high. And just many of you have seen this map before, and every time we present it, the African continent still pops out. At the moment, we're kind of between 10 and maybe 30%. South Africa has just reached, I think, 46% vaccine coverage. So we're well behind, and there are multiple reasons for this. One reason, perhaps not quite so prominent now, is vaccine supply, but it definitely kind of prevented the rollout from accelerating when it was most needed. Here are the South African latest figures, and you can see that even between provinces, there's quite a large difference. For example, where I'm based here in KwaZulu-Natal, we're one of the worst provinces in terms of performance. Only 40% had any vaccine. The Western Cape has done better. We've also seen that in Sisonke, that the Western Cape has done fairly well. And overall, we're still below 50%, despite very good vaccine access now. Very quickly, some very basic vaccinology. I know most of us know this, but as SARS-CoV-2 is obviously a single-stranded envelope RNA virus, which is comprised of about 29,000 nucleotides. And the variant has 4 structural proteins. One of them is the spike protein. And I think we were quite lucky in some ways that the scientists focused on the spike protein that the virus uses to enter the cell as our main focus for vaccine development. And the success story really of developing vaccines so efficiently. On the right, you can just see how the virus then enters the cell through that ACE2 receptor. The virus enters the cell, the RNA gets translated into proteins, then you get reassemblance, and the immune system then recognizes the virus and communicates with the T helper cells, which then talk to B cells that make our antibodies, and T cells that cytotoxic T cells that can destroy infected cells. And then you get that laying down of memory. But I think one important aspect why I'm showing this is that originally most studies, phase 2 studies and phase 1 studies, did some neutralization assays as well as antibody studies. Not all of them took PBMC samples to do a good T cell work. So a lot of the T cell data has actually come out much later and is also starting to inform now, particularly on durability of vaccines. So very quickly, the various vaccine concepts, and it's quite remarkable how the array of different vaccines that have been developed over time has also been tried and tested for COVID. So on the left, you can see those inactivated virus vaccine or weakened vaccines like, for example, Sinopharm and Sinovac. In the middle is the replicating viral vector vaccine that has been used against measles. It's very effective when it works. Unfortunately, Merck very early on decided not to make any COVID vaccines, so they kind of stopped that development program. Then we've got the non-replicating vector vaccines like the adenovirus vaccine of Johnson & Johnson's or the AstraZeneca vaccine, and protein subunit vaccines that have been investigated also more recently. So for example, Novavax, as well as the Sanofi program. And then obviously the latest vaccines, many DNA vaccines have been tested, and then the famous RNA vaccines that have really revolutionized vaccine research now. And here, I think the one important aspect is that these vaccines with the lipophilic layer enter the cytosol of the cell, but don't need to enter the nucleus even, and can create these viral proteins that are then recognized by the immune system. So very briefly, I think South Africa has made a fantastic contribution to clinical trials overall. So we were certainly part of the Pfizer vaccines, the early ones, that showed that incredibly high efficacy of about 95%. The J&J vaccine was really spearheaded by Linda Gale and Glenda Gray and others in South Africa during the beta wave. The Novavax study with Shabir Mahdi and others also started very early on in South Africa. Unfortunately, AstraZeneca program had to be stopped because of that low efficacy against the variants. And more recently, we've been starting to work more productively with Moderna on this Ubuntu trial, which I'll tell you a little bit more about in a minute. So in terms of effectiveness of vaccine, perhaps it's good to just think about these beneficial effects, and they're essentially 8. So we look at those individual benefits. First, we see a reduction in asymptomatic infections. We also see a reduction in clinically apparent infections, in severe infections, in hospitalizations, in death. And then more recently, a lot of data has come out on long COVID and the reduction of progression to long COVID when you get infected despite having had a vaccine. Obviously, effectiveness needs to be considered within these realms of the type of vaccine, the time since the last vaccine, so durability, and then also the variant. And I would probably add one component, which is your immune status to this package. So if we look at some of these in more detail, we can see that this is a paper from Nature, which just described the reduction in, or the vaccine effectiveness against asymptomatic infections. And this was well described for Moderna with a 66% reduction. For AstraZeneca, the same, about 49% there. And even in Sisonke, we saw, that hasn't been reported yet, but we saw a minimum of 30 to 40% reduction after a single dose of J&J in the asymptomatic infections. Here you can see some of the vaccine efficacy data in the trials. Some of them we were part of. And this is against clinically apparent SARS-CoV-2. So let's say mild to moderate disease. And we can see that efficacy was pretty good. The J&J efficacy there's after the single dose vaccine, but generally speaking, very high efficacy rates. Perhaps Sinovac was a little bit low at the 50% mark. And then obviously, the impact of variants has very much impacted on our response and also on vaccine effectiveness. It's given us many headaches. So here are just 2 examples of AstraZeneca and BioNTech Pfizer, because these are probably the 2 best described vaccines. And we all experienced that huge reduction in efficacy against beta in a relatively small cohort in South Africa, which then stopped the rollout. The reduction by 10% in Delta that was described in the UK. And then some studies showed a very high reduction against Omicron. However, that was probably about 6 months after the last injection. So you remember that the UK rolled out the vaccination program much earlier than we did. So when Omicron hit, most people had already had the vaccine about 6 months ago. You can also see the boosters. So particularly well described from Israel for the Pfizer booster. You can see that even the Pfizer prime was reduced to about 76% after boosting. But in general speaking, the Pfizer vaccine against beta. I think that 95% is a very small study. I think that's just a single arm, so maybe difficult to interpret. I wouldn't be surprised if there was also a reduction. And then Delta and Omicron, again, quite large reductions in efficacy against the primary vaccination schedule. So how are vaccines then doing against severe COVID? And Graham mentioned this already. So we've got now quite large cohort data and real-world effectiveness data from the New York State. That was about 8.8 million people in there. And then also the Kaiser Permanente cohort, looking at hospitalizations. And you can see even at month 6 or month 4 here for the New York State, but month 6 for Kaiser Permanente, you could see these very high efficacy rates with Pfizer, Moderna, but also J&J, still up to about 83%. So Linda Gerbecker and Glenda Gray, together with Shirley Colley, did a nice early analysis in the discovery data set and showed that 2 doses of Pfizer also protected still against Omicron by about 70% in the very early days of the Omicron epidemic. And that really leads us to this T-cell response. So we're learning a lot more about that. And a lot of that has been described also at UCT by Wendy Burgers and others, that the T-cell responses are probably much more important than we thought. And they're extremely important in preventing us from being admitted to hospital or perhaps even dying from COVID. So here's a study of 96 adults with various vaccines, Moderna, Pfizer, J&J, and Novavax, looking at various variants, and then also looking at CD4 positive T cell, CD8 memory T cell responses at about 6 months post-vaccination. And you can see that most of them are highly preserved against Omicron, but also other variants. And then the recent CDC report here shows us, gives very good evidence about obviously the benefit of vaccination to prevent death. And you can also see that maybe 6 times reduction, further reduction in death with the additional booster. So if everyone thinks about getting vaccinated still, I think it's definitely worthwhile getting that booster. Although the margin is obviously, the proportion is, the margin is much, additional benefit is much less than from unvaccinated to vaccinated. And then this is an interesting study about long COVID, where they followed people in Israel. It's actually a cross-sectional study of patients tested between March 2020 and November 2021. And they looked at symptoms amongst people who had not been vaccinated and had COVID versus those that had breakthrough infection with either just a single dose or 2 doses of vaccination. And they found a clear benefit, 54% to 64% reduction in the 4 most common persistent long COVID symptoms. So even if you do get COVID, despite vaccination, it seems to have some beneficial impacts for the individual. If we then look at some of the community benefits, we can just see here, so COVID-19 vaccines reduce the infectiousness by lowering virus levels and therefore then decrease the spread of the virus. This is an initial report here presented in Nature Medicine. And they found a significant drop in viral load from about 2 to 4 weeks after the first dose of Pfizer, and similarly reported to us for AstraZeneca low viral load in vaccinated compared to unvaccinated people who do get infected. Now, when we look at this at a more community level then, and obviously how that impacts on public health as well, in Singapore, they had 218 individuals in here. And you can see the green line is the viral load post-infection amongst vaccinated versus the red line amongst unvaccinated. You can see that the viral load decreased much faster in the vaccinated. This has been less well described at this stage for Omicron, but we were suspecting a very similar pattern. And then finally, this is quite a nice study that was done at the time when children were not really vaccinated at the time, which showed the indirect protection of children from SARS-CoV-2 infection through parental vaccination. So you can see here, parents were vaccinated with Pfizer. They were 94% protected, and then the children were about 72%, had a 72% lower risk of getting infected if they lived in that family. So just a couple of additional slides. So these are some common questions that we get as clinicians. I had COVID-19, do I still need to vaccinate? And here's one study that clearly shows there is an additional benefit and a reduction in reinfection by about 82%. This was a large study of about 150,000 patients with past infection, and 56 of them were vaccinated, and they saw a reinfection rate of 2.5% among the vaccinated compared to 10.2. And perhaps this is a nice, I think there's a very nice diagram from Shane Crotty here presented in Science, where he just tried to explain this even more. So obviously natural infection is a good thing in terms of immunity against the virus, but vaccine immunity is better than that if you have a full course of vaccination. But hybrid immunity, so natural infection followed by vaccine immunity, is even better, leads to even better memory B cells, antibody responses, and CD4 T cells, and natural killer cell, cytotoxic T cells. So Graham asked me just to talk a little bit about heterologous boosting, because that's become very relevant now that we can choose between J&J and Pfizer for booster. And here you can just see a very recent summary from of the US data, who, as you know, also rolled out J&J single dose initially, and then provided everyone with an mRNA boost. Or have, obviously, here you can see the 3 mRNA as well. So you can see on the right-hand column the various efficacies. So J&J 2 doses is about 54%, and this is at about 6 months, I think. And then J&J single dose followed by RNA slightly higher, and then a 3-dose mRNA regimen would be even higher than that at 83%. If you look at hospitalizations, again, any boosted is quite high, with 2 doses of J&J 67%, 1 J&J and 1 mRNA of 78%, and then 3 mRNA doses of 90% protection against hospitalization. This is quite a busy slide, but I thought Ed Parker gave this talk for the CoVPN, and I quite liked it because you can almost pick your own regimen here, and you can see the antibody responses, first of all, against vector-based vaccines that are boosted with either vector or with mRNA. And you can see at the bottom, anything towards the right of the dotted line favors heterologous boosting, and anything to the left of the dotted line favors the homologous boosting. So you can see here in this picture, most of the binding antibody studies and neutralization studies favor some of these studies that use the mRNAs as a booster, particularly for AstraZeneca, that's been described very well. With very high neutralizing antibody titers. And then here you can see the same for mRNA vaccines. And you can see that there's really not much of a difference here, although there may be a slight benefit even here in one of the studies of AstraZeneca followed by mRNA, versus homologous double mRNA. But overall, I think the dots are all very close to the dotted line. So it's a bit of a matchness what you choose, I think. Just reminding everyone, this is an antibody study, and we know that antibodies wane relatively quickly. It's not a T cell study. So that needs to be kept in mind when interpreting these results. So I'm just going to quickly speak a little bit about what we've been doing. I think many of you have been part of the initial Sisonke study, either as maybe investigators or as participants. And you'll remember that that was rolled out between 17th of February and 17th of May of 2021. The overall effectiveness paper came out, I think, about last week in the Lancet. And it's very nice to see some efficacy data presented. So on the left, you can see the hospitalizations in the trial. And below that, you can see the actual numbers, the cumulative events amongst unvaccinated versus vaccinated. So this was a matched, adjusted match control study where we matched our Sisonke participants with the MedScheme and Discovery insurance clients, and we also adjusted for confounders. And on the right, you can see the deaths. So if you look at it, this was just 215,000 Sisonke participants that we could match, but here we prevented about 600 hospitalizations within about 4 months and about 140 deaths within that same time span. Maybe if you extrapolate that to the entire cohort, maybe optimistically, that could be about 1,500 hospitalizations and up to 300 deaths. So I think it was a worthwhile intervention and an important project we all worked on together. This is just preliminary data presented by Glenda Gray and others from the Sisonke study. On about half of the Sisonke participants came back to get the second J&J booster. And this is really the first evidence of effectiveness against Omicron. So we enrolled participants from the 8th of November to the 17th of December, so about 6 to 9 months after their primary vaccination. And we did this test negative design study, adjusting for confounders to estimate the vaccine effectiveness of this second dose, or you can call it the booster, of healthcare workers compared to unvaccinated individuals. And again, you can see quite high effectiveness against hospitalization very early on during just post-booster, up to about 80–90%. Particularly in the, we also looked at Gauteng, that was the epicenter at the time for Omicron. And so what we're planning now is we're aware that everyone has access to the Pfizer booster or another J&J. We have engaged with Moderna, and they are willing to work with us on a booster study. So they've got a 50 microgram booster, which is half the dose of the primary regimen. And we've designed a study which is currently with SAPRA and the ethics committees, which we would like to conduct, and anyone who's happy to still join. People could be either single dose J&J Sisonke participants or anyone who had a booster and is 3 months after their booster and could come in for the mRNA boost. And we're hoping again to do a analysis then comparing the Sisonke participants who received this booster versus those that didn't. Also, obviously, keeping in mind that many have now had access to Pfizer. A little bit additional information I wanted to share is on the Ubuntu study. Again, several of the UCT sites and clinical research sites are part of this 3008 co-VPN study, where we're looking at Moderna primary vaccination, but predominantly amongst people living with HIV in these 8 sub-Saharan East African countries. And this really springs from the this table that was put together by Richard Lesselt about essentially several of the trials that we've been conducting. But unfortunately, many of the eligibility criteria either excluded people living with HIV or included only stable people on ART and with higher CD4 counts. Again, the number of endpoints in many of these studies were extremely low, particularly amongst the people living with HIV. You can see that they're on the right. So it was very difficult to draw any meaningful conclusions from these studies on this subpopulation. And a recent systematic review and meta-analysis for COVID-19 vaccine amongst people living with HIV just summarized some of these, the knowledge that we know so far. So there have been quite a lot of observational studies now, a smaller scale, that showed that people living with HIV have slightly less IgG antibodies and also neutralization responses to vaccination. Particularly if the CD4 count is below 500. The general VE has been estimated to be about 95% among vaccinated compared to unvaccinated. And people living with HIV with a CD4 count of less than 35 had particularly low vaccine effectiveness, here 59 versus 72%. Interestingly, the vaccine tolerability amongst all these studies seemed to be very similar amongst people living with HIV and those that are not infected. So we've designed this study that's now ongoing. We've already enrolled 6,000 participants amongst the 8 countries. And it's gone through several iterations to keep up with the guidelines, etc. So this is the latest study schema where we are proposing to compare a 3-dose regimen versus a 2-dose regimen, 3 doses amongst seronegative participants and 2 doses for those that have already had natural infection or evidence of SARS-CoV-2 antibody positivity. And then we'll give a booster at month 6 for everyone at the moment. The sample size is 15,600. It's quite a large sample size. We purposefully increased it slightly so that we could potentially add in an additional design change, which would include a variant of concern booster, which Moderna are currently working on, the Omicron booster. So it would be nice to randomize people in each group to either the ancestral vaccine versus a variant of concern booster. And as part of the study, we are planning a large immune correlate study, study of protection. So you can see large numbers of people having PBMC samples taken so that we can do T-cell assays and look at correlates of protection within these subgroups in detail. Just an initial finding, which was quite interesting. I think this is consistent with what some others have found, that we saw a very high SARS-CoV-2 PCR positivity rate at enrollment into the trial, up to 40% amongst those that was SARS-CoV-2 seronegative with a low CD4 count. And you can just see that correlation graph. In blue are people that are seronegative for SARS-CoV-2, and in red you can see those that are SARS-CoV-2 seropositive. And then on the x-axis is just the current CD4 count of those participants. And you can see that some of those goes extremely high to up to 60–70% amongst those with very low CD4 counts. And this is obviously interesting in terms of this study, which many of you know about now, individual cases that have been reported where we see persistent viremia amongst people with very low CD4 counts or immunocompromised people, also described in the UK in cancer patients on chemotherapy. And in this case, particularly when ART was finally started, effective ART, you could see the reduction in the HIV viral load, but also then closely followed by the reduction in SARS-CoV-2. I mean, the key here is really the emergence of variants during the time. I think it was a roughly 7 months period where there was persistent shedding. So I think Ubuntu will hopefully give us the opportunity to, investigate this kind of phenomenon on a larger proportion, if possible. And just very briefly, I think why many of us in the HIV field are interested, and obviously COVID, is that a lot of the HIV vaccine technology was transferred to and translated rapidly to COVID. For example, the mRNA, some of the mRNA research was done at the NIH, which was originally tested on HIV. And the question now really is, how can we efficiently translate some of this knowledge and technology back to HIV and improve our vaccine research on that side? So one element that has been discussed a lot, and one of our colleagues, Lynn Morris, wrote an editorial about this, how mRNA technology can help us to administer various immunogens, so what we call maybe sequential vaccination, that can shepherd the immune system to create these broadly neutralizing antibodies that are potentially potent enough to prevent infection with HIV. We've described these antibodies extremely well in many of our cohorts, and the problem at the moment is that they develop far too late, about 2 to 3 years in the natural host and natural infection. So if we could get the immune system to make them much earlier and prevent infection that way, that would be one strategy to move forward. So in conclusion, it's been a remarkable scientific journey for all of us, I think, in the last 2 years, but the pandemic is not over yet. Increasingly more vaccines are available now, but the rollout across Africa is lagging behind. We have a much younger population here, but perhaps we're not really accessing or giving that population sufficient access to vaccines, engaging that population enough. Vaccines are remarkably effective, but vaccine effectiveness is impacted by the vaccine type, the variants that are obviously putting pressure on the responses, the timing of the vaccine and durability, and then also the immune status of the participant. And then South Africa has made a huge contribution to COVID vaccine research and to the response at large. And it's key to translate now this technology and knowledge to HIV and also TB and other diseases, and ensure African countries are part of this journey. And I put this up because this is one of the initiatives from the African Union. And I know that Annelies Williamson from UCT is very much involved in this, been one of the working groups, and it's been an exciting program to really galvanize the vaccine program across Africa. With that, I'll just want to quickly thank all the Sisonke team, investigators and participants, the sites, and also the Department of Health and others. And particularly thanks to Slim and others here at Caprisa and the Ubuntu protocol team. Philip is on the call as we speak. Particularly thanks also to the site investigators and the regulators, and above all the ethics committees who've been brilliant in the last 2 years supporting a lot of these trials. And then last but not least, the participants that joined the studies. So a big thank you also to you, everyone who helped out with the COVID response in 2021 and 2022. I think now we have evidence that we did save lives. And I just remember when Sisonke started, I think the first person who got a vaccine was our president at Khayelitsha Hospital by one of you people from UCT. So that was a great moment and a nice memory. Thank you all for listening.
Thanks so much, Nigel, for a really excellent overview, a comprehensive talk. It really is a massive topic, given the amount of knowledge that's been produced in this field in the last 2 years. And you've really highlighted the salient learning points and the main issues. So thanks for that overview. Just to say to the audience that if you have questions, please type them in the chat, and Wendy can pose them to Nigel. My first question that I want to ask you, Nigel, was just if you have knowledge or can share with us any knowledge that you have about next generation vaccines that will, you mentioned it briefly with respect to the Moderna vaccines, that will provide improved protection against variants of concern. Obviously, one of the big issues over the last few months is the degree to which Omicron has escaped immune responses in terms of protection from infection. And are there vaccines on the horizon that will specifically protect against Omicron and potential future variants that are immune escapes?
Yeah, good question, Graham. I think definitely Pfizer and Moderna have been working on variant vaccines for some time. I do have a couple of slides on that, but I think they started off with beta, and then beta disappeared and Delta came along. And I think the strategy then was to design more multivalent, kind of that have a little bit of beta, a bit of Delta in it. And now they've just started the first phase 1, phase 2 study on the Omicron variant booster.
Mm-hmm.
So I think the problem has been that we've always been a little bit one step behind. By the time the variant vaccine was available, the next variant was there. So even in Sisonke, we discussed this at length, and then we felt, okay, Omicron, we give an Omicron vaccine instead of a solid vaccine that has been studied. Could that actually mean less protection, or could it even force the virus, to mutate towards a more virulent or more pathogenic virus again? I think at the time we realized that there's a lot of transmission with Omicron, but perhaps not as much disease. So I think we were a bit uneasy about using an Omicron booster at the time for that reason. But I know that, and then obviously then the other thing was that a lot of the, Israel data came out on the third vaccine, the booster, and it showed very good effectiveness with the ancestral boost. So I think there wasn't really quite as much of a need and maybe a market for a variant booster. I know that I think the latest discussion at the NIH is to kind of come up with a pan-coronavirus vaccine, really, that can cover multiple variants, but also potentially multiple SARS-CoV-2 or SARS-CoV viruses. More of a universal type vaccine, and then perhaps a universal type booster. But I think there's quite a lot of kind of preclinical work on that being done. But I'm not an expert on that at this stage.
And just to clarify, in the trial that you're going to, the Ubuntu trial, the variant of concern vaccine, what variant would it be targeting?
So that would be an Omicron type variant.
Okay. Yeah.
And we would actually like to randomize each group into Omicron versus ancestral, which would also help us to get an idea of whether there is any benefit of those kind of boosters. Because you have to remember, hardly any phase 3 trials are ongoing at this stage. I think people are just rolling out vaccines. So we do have an opportunity, as long as we give everyone a vaccine and no longer use placebo, I think, to still look at some of those questions.
Thanks. I'm just going to turn it over to Wendy if there are any questions from the chat.
Yeah, we do have a few questions. The first question is there any data on BE from 2 doses, so vaccine efficacy from 2 doses of J&J, and then followed by the Pfizer booster?
Yeah, I think that's a combination. Many of us in South Africa, let's call it mRNA boost for now, are going for. And it certainly showed, so if you look at those ED's immunogenicity summaries, it looks like one of the very strong combinations, mRNA. So J&J followed by mRNA is definitely good in terms of neutralizing antibodies. And also the effectiveness data at the CDC shows quite high effectiveness, so at 80% odd. So I think it must be a very good combination, and it's been used in the US a lot now, because they started off with J&J and then gave everyone Pfizer or Moderna.
And then another question, if you've had both J&J and Sasonki trial, when and should one get an mRNA booster?
Sorry, can you just repeat that?
So if you had both the J&J vaccines as part of the Sasonki trial, when and should you get the mRNA booster? So what is the timing after having two J&Js?
Yeah, so we should really ask that question, Erna, perhaps, because a lot depends on when the next wave is. I discuss this a lot here at Caprizo, and we always say it takes 79 days from the end of the one wave to the next, which I think would take us to the 6th or 7th of May. So I guess that the booster should probably be taken at least 2 weeks before then, if possible. Even if there may not be a wave, I think it's still probably a good idea to get a booster in the next months. What we generally say, so the Sherpa study is hopefully going to start soon in the next 2 to 3 weeks. So people could also get then access to the Moderna booster, which has been shown to be at least as good as a Pfizer booster, perhaps a little bit better even in terms of durability. But yeah, so I think that's definitely a good idea to get the booster then and then be fully protected in case there's another wave. And sorry, in that trial, we say at least 3 months after your second J&J dose.
Any comments?
Sorry, Wendy. So Nigel, that would be the same in terms of accessing a Pfizer within the national program, at least 3 months.
We would do this through the research sides with reimbursements, but also, consenting, but a single visit, mainly because the vaccine is not licensed yet, but we have indication now from Moderna that they're very keen to license the booster as well as the primary regimen. So I think that's one reason why we're now pushing to also get another good vaccine that's available, and obviously work with Moderna, who are strong in the HIV mRNA field, hopefully be part of some of that program as well.
Sorry, any comments from your side in terms of timing?
I don't want to speculate on timing. I really don't. So SARS-CoV-2 keeps surprising us. So I would advocate that everybody get their booster as soon as possible. I really don't think there's any additional harm in getting one. And if we are going by that timing, then the wave is arriving soon. And those of us who did take part in Sasonki 2, we're past our 3 months. So please do go get your boosters, everyone.
Thanks. So 2 questions from Johnny Peters. Some emerging data about long-term protection from severe disease after 3 doses, and then thoughts about continued boosting with ancestral strains. Do you think we could see a move towards the influenza model?
Okay, I think he's, sorry, Johnny asked about 3 doses, is that right? And then, so there's obviously, I think there's a lot of data. It started coming out from Israel about the 3rd dose, how it really boosts the immune system and brings up the vaccine effectiveness to over 80% or maybe even 90% again. So that's been the main strategy there. Israel has also gone for 4th vaccine for several people. I think they focused that on the very much elderly population, I think over 70. I'm not entirely sure whether they've already evaluated that formally. But in terms of, I think Johnny is asking about like annual vaccinations, I guess, similar to in certain perhaps risk groups or so, similar to the flu vaccine. I'm not sure whether we're able to answer that question yet, because it really depends on the epidemic, I think, whether we're getting frequent waves or not.
There's a question, there's much to be said about the boost that the COVID-19 vaccine response could have on vaccine design and development for TB, HIV, and malaria. Could you elaborate on what specific scientific knowledge is gained from the COVID-19 vaccine response that can be translated directly to TB vaccine development? And that's from Valerie Berza.
That's a good question. I wished, I'm not sure whether I'm the right person to, I'm not a TB vaccine expert, but maybe Graham, are you? I mean, I'm sure that, I mean, it's interesting how mRNA technology, I don't know. I don't know whether that can actually help with the bacterial organism, whether we can use some of the knowledge. Can you elicit certain T-cell responses that may help in fighting TB or latent TB? Yeah, maybe I'm not the expert on that topic.
Yeah, it's a big topic. I mean, I think that some of the technology platforms can surely be used to accelerate TB vaccine development, but I think all of these would need to be evaluated in TB specific trials, and whether you developing the correct immune responses that are required for protection against TB, and the challenges around, you know, what are the correlates of protection that we're looking for is still, you know, it's something that can only be really addressed in the TB research field, but it's certainly the new platforms that could be harnessed within TB.
We've got a few other comments. With respect to the variant vaccines being behind the variants, what are full efficacy trials for variant vaccines envisioned? We don't usually do that annually for influenza. The time needed for such trials means that the variant may have passed before the vaccine is actually available.
I think I'm struggling to hear the question. Graham, can you just repeat it?
Sorry, let me say it a little bit louder.
So with annual vaccines, are you saying, Wendy, the trouble might be that the wave has passed before?
By the time we've actually sort of developed that variant vaccine, the wave might pass and we're on to the next variant.
Yeah, I think that's exactly what's happened. So that is I mean, it's a difficult business model as well for companies who are investing in this kind of research. Because, so this happened to Moderna as well as Pfizer, I think, that they had a variant vaccine ready when it was already a bit too late.
Mm.
There's a question here from Barry Bloom. How do you reconcile long-lasting T-cell responses and the waning protection and neutralizing responses? Are T-cells really important?
Yeah, I think the durability data has really been striking, how severe disease protection lasts so long. And we do know that antibody titers are waning from about 3 months or so in most of these studies, in even the mRNA vaccines. So we're pretty sure that this is the additional protection is due to the T-cell responses. I think, and I think this study that I showed just shows that the T-cell responses are durable. I think we're still learning a lot about this, but I think this is just one study. I think Wendy Burgers has shown similar findings.
I think we've probably got there's one other comment. Is it agreed that evidence-based public health position on mixing vaccinated and unvaccinated people in indoor gatherings? So the risk of mixing indoor unvaccinated and vaccinated individuals, is that a concern?
Yeah, I think that's a good public health question that we're debating at any stage in the pandemic. I guess a lot depends on, you know, force of infection and how much virus is circulating. I mean, I think I'm obviously pro-vaccines, but I also understand I don't want to exclude people from enjoying their lives. So, I mean, maybe the compromise of doing some of these rapid antigen testings at these events is a good intermediate step, I think, so that you have some sort of safety. as people who are vaccinated are still getting obviously infected or can get infected and may be vulnerable.
Thanks. Graham, I think we've covered most of the questions.
Yeah. Nigel, I think that last question is a really challenging one because it's such a moving playing field in terms of, that which variant you're dealing with as to how much protection against infection you're getting from vaccination, and then at what stage you are in the epidemic curve, if you're in a wave versus outside a wave. I think the answers will be different. It's something that I think even in the midst of a wave, even if you have a lot of people vaccinated and you've got a variant that's an immune escape circulating, then that's in itself not going to be protective. Whereas outside a wave, it's obviously going to be a lot safer. So yeah. I think it's difficult to answer that question without knowing the exact conditions one is dealing with.
Yeah. Graham, maybe one last thing. What we're learning in Ubuntu is it's extremely easy to recruit still, which I think is so disappointing in some ways. Obviously we're looking at people living with HIV, but the recruiters are all saying it is very easy to recruit, which I think is a real shame, and shows again that I think maybe that is a very vulnerable population that just doesn't, for some reason, have had access to a vaccine, and maybe our public campaigns just weren't quite reaching everyone. That's maybe why we're still stuck at like 46% here in South Africa.
Thanks very much, Nigel, for a really great overview this afternoon, and thanks everyone for joining us. Our next webinar will be next month, and we'll send out notice of the date for that. We're hoping to have a topic dealing with the long-term cardiovascular complications of COVID, but we will send out details. So back to you, Wendy. Thanks very much.
So once again, thank you everyone for joining us and for all the questions, and we look forward to seeing you again in a month's time.
Thank you.
Thank you.
Thanks, Anna.
Bye.
Bye.